This is the research room. Hello.
Hello.
Welcome back to the research room with me, Lucy Ather.
And me, Janine Healy.
And today in the research room, we're very excited to be joined by Emma Reay and Nick Johnson from the SCOOTT project. Welcome to the research room.
Thank you.
Good morning.
Thank you for having us.
Thank you.
Yeah, you're very welcome. So just to start us off, could you introduce yourselves for us? Should we start with you, Nick?
Yeah, good morning, everyone. My name is Nick Johnson. I'm a consultant hand surgeon at the Pulvertaft Hand Centre in Derby, but I've also got a research interest, so I'm involved in several trials looking at the effectiveness of treatments for hand surgery problems.
Great, welcome.
Thank you.
And Emma?
Oh, hi, I'm Emma Reay. I'm a consultant hand and wrist surgeon from Middlesbrough, and I am the co-chief investigator of the SCOOTT trial with Nick.
Brilliant. Thank you so much for coming in. So you're here to tell us all about SCOOTT. Could you tell us, first of all, the full name of the project?
Yeah, so SCOOTT stands for Surgery versus Conservative Osteoarthritis of Thumb Trial. So it's SCOOTT with two T's at the end.
Ah, yes, SCOOTT.
Yeah, and as the name suggests, it's comparing surgical treatments with conservative measures.
Ah, right, okay. So we have a little competition going, don't we?
Yeah. Most projects have a short name, and we have the little competition.
Yeah, we're rating everyone's acronyms.
Nice.
And I know I say this every time, but I actually really like SCOOTT. I just like the sound of it. Like SCOOTT.
You like
Nice
the name?
word.
Yeah.
I like acronyms that are like a bit more fun to say.
Okay.
Yeah. Do you like it? You don't look like you like it.
I think it is a nice name. It's a good name. Does it fit with all the letters of the word, the trial name?
Yeah, it sort of does. We kind of took a little bit out of one and a bit out of the other, but yes, it kind of fits.
Yeah, because it's, what was the S?
Surgery.
Surgery, conservative?
Yep.
Osteo, is the O, osteo, what's the other O?
Of.
Oh,
Osteoarthritis
of the thumb trial.
Trial.
Okay.
SCOOTT.
Yeah, that's pretty close to a nice.
It's nearly.
You're quite picky
I am very picky.
with
so
the
don't
words
ignore.
being absolutely perfect.
Yeah, I am. But it is good. Is the name SCOOTT is good?
Yeah,
Because you remember it.
yeah. It is memorable.
Yeah.
What would you give it out of 10?
You always ask me first.
Okay, I'll go first. I'm going to give it. Can I give it a 7.5?
Oh, that's unusual.
Yeah, I've gone for a 0.5 this time.
Yeah, okay. I always find it difficult because they're staring at me. And
There's no pressure.
you think, I can't give it a low mark. But I think probably, a 7 a bit. Yeah, 7.
Yeah.
Not too bad.
That's not too bad.
That's reasonable.
Yeah.
Yeah. Did you come up with the acronym?
I think
Did I do
Nick
it?
did.
Yeah.
Did you?
It took a while and it's a
It did.
3-arm trial as well, so that makes it
Yeah.
harder. So
Oh,
think
yeah, you've
with-
got more treatments to try and fit
Fit
into
in.
the name.
Oh,
Yeah.
of course. Yeah. Oh, perhaps we should have given you an extra point for
Ah,
difficulty.
Oh,
Too
okay.
late now.
Oh, yeah.
So, in a nutshell, can you describe your project? What's it all about?
Okay. It's a randomized control trial, and as we've mentioned already, it's a 3-arm trial, and we're looking to compare operative versus non-operative management of thumb-based arthritis for patients who need surgery, and to decide really what is the best management for patients who present with pain at the base of their thumbs that essentially have got to the point where they're thinking about having surgery.
Yeah.
And when that decision has been made to have surgery, whether or not surgical intervention is better than non-surgical intervention, but with an enhanced package of non-surgical intervention,
Ah,
or if they go down the surgical route, whether the two options for surgery that we now routinely offer patients, are they similar in their outcomes, essentially?
okay.
So we are lucky in the UK that we are able to look at sort of newer interventions and compare them using randomized control trials. And at the moment, there are 2 surgical options that are most commonly performed for patients who have symptomatic thumb-based arthritis. One is, it's called a trapeziectomy, where we take the little bone out. And the other is called a thumb base replacement, where we replace one of the little joints at the base of the thumb. And we are just in the UK starting to use the thumb-based replacements more routinely. And we wanted to make sure that the outcome of that is just as good as the outcome from the trapeziectomy, which has been the standard treatment for many, many years. We're also really wanting to see whether or not an enhanced package of non-surgical intervention would be as good at relieving patient symptoms as surgery as well, because we don't really know whether or not that would be the case, because it hasn't been asked. That question hasn't been asked yet.
Okay.
So that's the trial in a nutshell, I think.
Oh, great.
Yeah, that's good.
Yeah. Quite often, when we've chatted to people about their kind of surgical trials, you find people saying, oh, there's this surgical technique that people have sort of started using more, but we need the evidence to back it up. So yeah, it sounds like that really. So you've got 2 types of surgery and you want to make sure or compare them, really.
Yeah, exactly. So essentially we've got a superiority part and a non-inferiority part.
Oh, wow.
I know, we're going technical, but
yeah.
but
I
exactly.
understand that.
So we want to know whether or not non-surgical treatment is superior to surgical treatment.
Yeah.
But then we want to compare the 2 surgical treatments and see if they're non-inferior. So they're similar, essentially.
As good as one is not worse than the other.
Precisely.
Yeah.
And the reason to do that is all to do with statistics.
Oh,
Don't
yeah.
ask me that.
No,
we're not going down the statistics road. Right. Yeah, that's really interesting. I don't think we've had a 3-arm
No,
trial
we haven't
before,
had 3.
have we?
No,
So you're not just testing one intervention, you've got 3.
Exactly.
Yeah.
And that makes it a little bit more complicated, but really quite interesting as well, I think.
Yeah,
and unusual, because we often, in surgical trials, surgeons like to do surgical interventions and like to test surgical interventions. But actually, the NIHR who funded the trial were very keen that we also have a non-surgical aspect to that. And that was led by patients. So patients wanted to know whether or not having surgery would be just as good as having surgery. And I think we found when we were looking into the treatment for thumb-based arthritis across the UK, it varies hugely depending on where you live as to what options of intervention you get. And that's why we wanted to make sure that we included the non-surgical as well as the surgical arms, because non-surgical treatment is more common in certain areas than it is in other areas.
Oh, so it's different all across the country.
Yeah. And is that just because the kind of preference of the doctors who live in different places?
It is, and it's also to do with the availability of some of the newer interventions. So the joint replacement isn't always available everywhere.
Oh, okay. Oh, very interesting. And could you tell us a little bit more about each of the interventions? So I think you said one of them was replacing a little bone and one of them was just taking the bone out, or are they different
Yes,
bones?
no, exactly. It's the same bone. So there's a little, so at the base of everybody's thumb, there's a little bone called the trapezium, which is a small sort of, well, it's a trapezial shaped bone, which is why it's called a trapezium. And both of the surfaces of that bone rub against or articulate or rub against one of the other joints. And it's usually the joint next to the thumb that becomes arthritic and causes pain. And one of the ways of relieving that pain is just to take that bone out completely so the 2 little joints don't rub against each other. Another way of doing that, which has been done for 15 years or more now, hasn't it? The thumb-based replacement is to replace one of the little joints at the base of the thumb with something that looks a little bit like an upside-down, teeny-weeny mini hip replacement.
Oh, cute.
Baby.
Which is very cute. And all my hip replacement colleagues, when I show them this prosthesis in the palm of my hand, looking at it, looks like just like a hip. And so that is now being much more commonly undertaken, and it is something that, so in Europe, for example, if you have thumb-based arthritis, you will have a thumb-based replacement rather than a trapeziectomy. That is now the first-line treatment in Europe. Whereas at the moment, the first-line treatment is still removing the bone, the trapeziectomy, but more and more units and more surgeons are now starting to use thumb-based replacement. So now, it's a good time to start asking the question, I think, to make sure we're doing the right thing.
Yeah. What made them change then? Is it just a whim, or they think it's better?
No, I think the thing is, as surgeons, we think it is better in the sense that we have a feeling that patients may get better quicker. The rehab is less. But actually, when you look at the evidence that is out there at the moment, which is limited, it probably shows that the outcome at a year is about the same for both treatments. But we don't really know, do we? That's the thing. And that's why we're doing it, because we're doing this procedure and we think we're doing the right thing.
Yeah.
But actually, we need the evidence to confirm that or refute it. We need the evidence to support it.
Yeah, definitely. The thumb joint replacements, people have been trying to make them for decades. But there were lots of problems with the previous designs. They used to dislocate. So the ball would pop out the socket bit. Because if you think about how mobile your thumb is, it moves in all different directions.
Yeah.
It's more mobile than a knee or a hip. So people have always thought that this was a big problem, and they've been trying to make the implant, but they never succeeded. There too many of them dislocated that they never took off. But this newer version looks like it has a 1 or 2% dislocation rate.
Right, okay.
And they've been using it in Europe for nearly 10 years now in some countries, probably in the UK. Some places have been using it for a long time, but most probably 3 or 4 years, I'd say. And people look like they're getting very good results with it.
Okay.
And the complication rate is low. So it does seem like they've solved the problem of the dislocation. So now everyone is starting to use them. The other important thing, of course, is cost for the NHS. And in the trial, we will be comparing the cost effectiveness across the 3 arms. The implants for the joint replacements cost about £2,000.
Oh, wow.
So, they're not cheap for the actual implant itself.
Yeah.
The trapeziectomy operation, you literally just take the bone out, so that hardly costs anything. And of course, the non-operative one, therapy one, you'd think would be relatively low cost. But we don't actually know that, because anecdotally, we think maybe the people who have the joint replacement get better quicker. So they often get back to work earlier. They come back for less follow-up appointments, less physiotherapy and things afterwards. Whereas sometimes the trapeziectomy, although it's a cheaper operation, may need more follow-up because it can take a bit longer to get going. And if they're having non-operative treatment, obviously that involves quite a lot of physiotherapy, hand therapy sessions, which all cost money.
Yeah.
So although you'd think the one with the very expensive implant would cost the most, we really don't know that. So that's something we're going to look at.
Yeah, that's always a really interesting aspect of it. I think the cost effectiveness is really important as well.
Yes, it is. So when they take the bone out, does that impact on how your thumb works, though? What doesn't that have a effect, how your thumb works?
Yeah, it's a really good question, and most patients always ask that. It's understandable. And that is one of the problems with trapeziectomy. You do obviously take that bone out, and there is a bit of a gap. And people have tried lots of different things in the past to prevent problems from the gap, because in theory, and occasionally what happens is the bone above kind of slips down. So the thumb you can get pain below there, and the thumb often isn't as strong. But the operation usually does take the pain away. So even though their strength might not be what it used to be, if they don't have pain and they've had, terrible pain for a long time, they're usually very happy and they can use their thumb more. But that can be an issue. That is one of the downsides of trapeziectomy, that there can be problems with instability and pain at the bottom of the metacarpal bone there that kind of can slide down into the gap. And people have tried things like putting bits of ligament, spare bits of tendon and things in there to try and hold it in place and stop that happening. And there has been randomized trials looking at that, and none of it seems to help, basically.
See.
And so the non-surgical intervention that you're also testing, could you tell us a bit about what that involves?
Yeah, so essentially a huge amount of work went into producing an evidence-based non-surgical package of care, an enhanced non-surgical package of care called the Engage package.
Oh,
I know, another acronym.
Another acronym.
Exactly. Oh, yeah. An Engage package, which essentially takes all the bits of knowledge that there is in the hand therapy community about basic thumb arthritis, and there's quite a lot, and puts it together and adds in some cognitive behavioral therapy and some pain coping skills to try and use everything that we have in our non-surgical armamentarium to help patients.
Sorry, what do you mean by armamentarium?
or
Like your arsenal.
yeah, exactly, or weapons
I
available.
like that word.
Armamentarian. Oh,
Sorry.
yeah. Okay. Yeah. It didn't fit with surgery. I'm sorry.
Did you think it was a surgical?
Yeah.
I thought it was
technique.
surgical term.
Yeah, no, it's just
I like that word.
Our box of tricks, essentially. Everything we have in our box of tricks from the non-surgical side. And I say we. It was put together by some of our senior hand therapy team that were working with us in the trial, and really to see whether or not doing everything that we know can work to improve symptoms without surgery does work. And does it prevent the need for surgery? Does it take the symptoms away completely? Because there is a fairly sizable body of thought within the hand surgery community that actually non-surgical intervention is the way to go.
Yeah.
And this is the thing with the trial. We all have our own ideas of what we think is the best thing to do. But we really need to make sure that we don't just go on our own feelings. We go on some evidence base. So hand on heart, we don't actually have the evidence yet to answer the question that we're asking, which is why, we do need to do this piece of research. I think everybody has their ideas about which in their hands works best, but we need a much more national opinion about that, I think, rather than just surgeon specific.
Definitely. We love a bit of evidence-based care, don't we?
Absolutely.
So the engage then, is that, so you mentioned a bit of therapy in there, and is it kind of physiotherapy and cognitive behavioral therapy? And then would you I don't know why I'm imagining his hand in a sling, but that doesn't sound right.
Yeah, I mean, you're not far off, essentially. What we found when we did the background work is that the amount of non-operative intervention each patient gets for base of thumb arthritis varies hugely, as with the other treatments around the UK. So some people will have had a load of non-surgical intervention. So hand therapy exercises, strengthening, splintage, maybe some injections before they get to the point where they see a surgeon who then has the discussion about surgery. And in some patients, they have none of that. And then they see the surgeon, and then they may go off and get either hand therapy or splintage or injections, for example. So I think what we wanted to do was to bring all of that together to allow what we would consider to be the best possible package of non-surgical care that we could offer, to see if that compares to the surgical intervention. Sort of to standardize it, and with the hope that in the future, that if we do see that it does prevent the need for surgery, even for a short time, then this package of care could become this kind of standard that we provide.
Definitely, yeah. I think we're going to give them hopefully the best non-operative care you can get in the package, and then we're testing if that works or not. Because as Emma said, there's so much variability in what they've had before, but at least we'll know that they've had a really good package of care. Hopefully it'll work. There is some evidence out there that it does work, but not high quality. But obviously if it doesn't, then we've shown that. Or maybe it works in certain people and not others, and we might be able to pick that out from the trial.
Brilliant. And so could you tell us a bit about the background to the trial and kind of why we need this trial, really?
Yeah, I mean, like we've been talking about, the joint replacement is a relatively new thing. Anecdotally, I think we do think that patients like it and probably get back to using their thumb quicker compared to the other treatment options. I think Emma mentioned earlier, it's almost been taken off exponentially now. So it's being offered almost across the country without great quality evidence yet. So we want to supply that. The other part of the background, I think we mentioned a bit earlier that the NIHR wanted this to be looked at because it is such a common problem. Pretty much everyone as they get older gets base of thumb arthritis.
Oh, really?
Yeah, it's really common.
Feeling my thumb.
You're looking at your thumb.
I am actually, yeah.
Yeah, it's an extremely common problem.
And I imagine it's quite painful, is it? And makes it quite hard to use your thumb.
Oh yeah, it causes a lot of problems with function, things like opening a jar, even turning a key in a lock.
Yeah.
Whenever you use your thumb, lots of force goes down to the base there, especially when you're doing kind of pinching activities. And it can be really uncomfortable.
I don't mean a jar, because I can't open jars.
Oh.
Oh dear.
You're going to be asking them to look at your thumb after this.
Yeah, I will speak to you afterwards. Do you think it's going?
Yeah. Yes, it is quite common. It is mostly affects women as well.
Oh, really? Yeah. Oh, that's interesting.
Oh, God.
I mean, you use your hands every day, don't you? For all sorts, for everything, really. Yeah. So, yeah, it must be a big problem if you can't use your thumb or if it's really painful to use your thumb.
In terms of if you did an X-ray of people over 80, like a really high proportion of people would have it.
Yeah.
It doesn't mean that they all feel it with lots of pain and are really struggling, but almost everyone gets it. Some changes in the bone and the joint at that stage. I think it's maybe 45%, something like that. Of people 60 or 70 plus have it. Yeah, it's high.
Yeah, that's sort of nearly half.
So, how does the project work? How are you doing this?
Well, it's a randomised trial. And it's patients who, the surgeon thinks are at the stage when they need surgery. So they've got to have arthritis at the base of the thumb and they've got to be struggling. So they're the type of patient traditionally would probably be offered a trapeziectomy, which is the standard operation for this problem. So practically what happens, they might come in via different routes, therapist, GP, and then they come to the clinic. Ideally, we try and identify them beforehand and give the patient some literature about the trial. And when they come in, we'd have a chat to them and explain about the 3 options and would they like to join the trial, and hopefully they'll agree to take part. And then normally the research team speak to them and they get randomised on the day and they find out their treatment allocation then. And one of the issues is because there's long waiting times in the NHS. So we had to design the trial carefully in terms of our follow-up time points, because traditionally your time points are related to post-randomisation.
Yeah.
But we know that some people's waiting lists are well over 6 months to a year. So it could be that if you just stuck to the post-randomisation time points, they might not have even had the surgery when you're doing the follow-up. So we've also added in post-treatment as well.
Right, okay. So you'll wait for them to have their surgery.
Yeah.
And then you'll give them the questionnaires and
exactly
measure whatever you're measuring.
Yeah, because I think most surgeons want to know, and for the patients, how do you do 1 year after you've had the operation? But if you're just looking at 1 year following the randomisation, they might have only just had it or something like that. So it doesn't give a true picture.
I see. Yeah.
Yeah, the NIHR are really keen that we make sure that we try and mitigate the waiting list problem. So it took us a while to come up with the plan, but I think it does mean that there are slightly more time points where we collect information, but it does work because the waiting time to go into the Engage package, for example, the non-surgical package is usually shorter. So we had to make sure that we collect similar time points for both.
Yeah, that makes sense, because you can't just say, right, 6 months after everyone joins the trial, we're going to give them all a questionnaire, because some of them won't have even had their surgery, some of them might have.
Exactly.
Right. And what are you measuring to kind of find out if it's working?
We're measuring quite a few things. The usual very big long list.
Now, what's your main one, though?
Well, the main thing is something called the OSCAN, which is the Australian measure of hand pain and function. Now, it's something that as surgeons in the UK, we hadn't really heard of before, because it's something that's been used in the hand therapy literature to assess outcome for base of thumb arthritis. So it's validated for base of thumb arthritis, but it's not something that we routinely use in the UK as hand surgeons. So that is the required outcome measure that the NIHR wanted us to use. So we use that, but we've also added in some extras because we wanted to make sure that when we come out with our results, the results are generalizable and understandable by everybody. So we've added in some more familiar outcome measures, like something called the PEM, which is another outcome measure looking specifically at the pain and function in your hand pre and post surgery. And that's another validated outcome score. We're using range of movement, as you can imagine. We're also working out grip strength. So when the patients get enrolled into the trial, when they're in clinic and they're going through the process of being enrolled, they will also do pinch strength and grip strength as well from both hands. And then they'll get that done again after their surgery as well. So that's another thing we're looking at. And then we're doing a bit of qualitative work, aren't we, as well, looking at the effect on quality of life and an economic analysis. As Nick said, it's really important because the actual prosthesis costs more for the thumb base replacement. But we wanted to work out whether actually it all balances out because we anecdotally have seen that patients with thumb base arthritis need less rehabilitation afterwards. So does it all average out? So we're looking at that as well.
Yeah.
And we're going to do some qualitative interviews with participants and with some of the staff members who've been involved in the trial to understand their experience of the trial, to see if there's anything they found was particularly good, particularly challenging, and see if we can use that information to make future trials better.
Yeah. Brilliant. Wow, you've got loads in there.
Yeah, lots. Did I miss anything out, Nick, or not?
I don't think so.
I was going through the list in my head. Oh, yeah, complications, yeah.
Oh, right,
Yeah.
okay.
So obviously if there's problems after it's probably going to be after the surgery if there are any issues, but we need to record them because that's the whole safety of the intervention.
Yeah.
So that'll be monitored closely as well.
Yeah. Wow, yeah, loads. So sort of pain, function, complications, qualitative work, economic work. Oh, loads.
Yeah,
Lots and lots.
And how long do you follow people up for?
18 months.
Oh, okay, yes.
18 months post randomization, isn't it?
Okay.
So we wanted to make sure that there is always a balance between making sure that a trial is economically viable and also will answer the question that you want to ask for a long enough period. So we're following up from that length of time for this bit, but we're also hoping, but part of the remit was to make sure that we also follow patients up for longer. That'll be a slightly separate bit to this trial, won't it?
Yeah, we'll probably have to get more funding for that, but we'd like to eventually do a SCOOTT too.
Oh,
and
great.
With the longer term follow-up, because obviously the people who maybe do well without the surgery, do they then, 3 or 4 years later come back needing surgery?
Yeah.
And probably the most important thing, like we were saying about the joint replacements, they seem to be doing well so far, but we still don't know. There's no long-term data on what happens with those. So ideally you want to know what they're like at 10 years and things. So hopefully we'll be planning something and be able to measure how they do much longer term.
Yeah. Oh, yeah, that'll be really interesting to see as well. Yeah.
Yeah, because hips and knee replacements, for example, shoulder replacements, even elbow replacements and wrists, they are all on something called the National Joint Registry, which follows the joint replacements up over time. And ideally would like to get the thumb base replacements on the same thing if we can.
Oh, yeah.
But to start with, we're going to collect the data on our patients, at least through the SCOOTT trial.
Yeah.
I didn't realise there was a registry for all that.
Yeah.
Mm-hmm.
So that's your aim, to get on the...
Absolutely.
Yeah.
With your little mini...
I know, I love the sound.
You can't see.
I've actually got a demonstrator in my bag. I'll have to show you it later.
Oh, yes, please.
Please. I want to see
We'll
the
take
little...
a picture of it. We put it on the...
Yeah, we'll take a
Snap.
picture. Yes.
Oh, yeah. Cute.
We need a hip replacement for comparison.
Yeah, I don't carry one of those.
You don't just carry a hip replacement round with you.
Why would you do that?
Oh, gosh. And sometimes with randomized controlled trials, they're what we call blinded. Are you blinding anyone in this trial or not?
No, we can't really. There was a question, but the issue is that the non-surgical intervention, you won't have a scar.
Yes,
The surgical
you'll know if
intervention,
you
you'll have a
didn't
scar.
have
Exactly. So
Oh,
it'll
so
be impossible.
we can't-
Yeah, exactly.
Yeah.
And that's the 3-arm nature of it. We could technically have done with the trapeziectomy, couldn't we? If we're comparing the surgical bits, maybe. But then some people use a slightly different approach.
Yeah.
And I think it was just going to be too difficult, wasn't it?
We did discuss it,
Yeah,
or
we
whether
did.
some time points could be blinded for the
Yes.
assessor who's doing them then. But I don't think there was much point. It wasn't
Yeah.
going to work.
I think it's quite hard, really, to have it all completely blinded, and just practically.
That's the thing, and I think we wanted to make sure that we created as pragmatic a trial as possible that was achievable in the real world. And I think blinding is great from a methodological point of view, but it's exceptionally difficult to do in a real world setting.
Yeah.
Yes.
And I think from a surgical trial, we just wanted to make it as easy as possible, because it's
Yeah.
not easy in itself, and we didn't want to add anything extra as well. So.
Yeah, and I think some surgical trials have been struggling recently to recruit and have even been shut down and things. So we wanted it to be as easy as possible for patients and staff, so that hopefully we can recruit and deliver the trial.
Yeah.
Talking of which, how
definitely.
many participants are you wanting to recruit?
672.
That's a lot.
Ooh.
It is a lot,
Yeah, that is
yeah.
quite a lot.
But it's obviously the 3 arms. We have to compare the 2 different questions,
Yeah.
surgery versus non-operative, and then we've got the comparing the 2 surgical options.
Yeah.
So that does mean, we need quite a lot of patients.
Yeah. So have you got lots of different research sites of hospitals signed up?
We've got 10 open now,
Yeah.
and that's on track for where we are. We're at month 11 in the 12-month pilot, and we're aiming for 20 at least by the end of the trial to be up and running. With regards recruiting, we're doing well. We're over recruiting at the moment. We're a bit
great.
above our target, and hopefully we should hit the pilot target ideally in the next few weeks.
Yeah.
Which is the one for end of November is when it ends. But yeah, we are on track for all of it to hit all our targets to progress to the full trial.
So what would the pilot is like a little test one, isn't it? And then you'll continue straight on, and after that, as long as you've recruited enough.
Exactly. It's kind of built in that we do the first year, and then unless there's any major problems, we should just continue straight on. And we're doing fine. But if we did pick up a problem with one of the arms, or we just couldn't recruit at all, then obviously the funders would look at that and have to make a decision about whether we continue or not. But fingers crossed it's going well so far.
Yeah. We've been pleasantly surprised, actually, haven't we? We've had a load of interest from the hand community, and they've been really engaged in SCOOTT and Engage. And we've also found that the patients have been so good at being involved, haven't they? It's really it's quite heartwarming, actually, the way how altruistic people are, because they know it won't necessarily benefit them, but it will benefit people for the future. And they've been we've got about 80% conversion rates of the people that we talk to and offer the trial to. That's 80% really of them, which is really good.
Yeah, that's
unusually good, actually. And that's down to the altruism of the population that we're looking at.
Yeah, I always think people are so nice. I think people are so willing to help out, even when it might not directly benefit them. A lot of people say, when people ask why do you want to be in the project and things, people just want to help other people, which is so nice.
It's so nice, isn't it?
It is.
Yeah.
Patients seem to really like the trial, as we've said, and we've actually had a lot of them come to us, and we've not advertised it a huge amount.
Oh, wow.
We're planning to kind of push it a bit more when we get more sites open, but when you start out, you don't have a good kind of coverage of the country, so we didn't want to push it too far, and then having people in Scotland or something who've got to travel miles to take part, wanting to get in touch. But the trial team regularly get patients contacting them wanting to take part. We did a little bit of work around Derby where I work, putting stuff just on the kind of Facebook and things from the hospital, and we got a lot of patients that way. So patients are out there and they're really keen to get involved.
Oh, well, it sounds all positive. It's all going well.
Yes, let's hope.
Touch wood.
We're not resting on our laurels. We're not taking anything for granted. We never know what's coming around the corner.
Yeah, definitely. Oh, that's really great.
It's good.
With respect to the patient side of things, I think there's a real push to make sure that trials and research in general is patient-based, which of course it should be.
Yeah.
And I think one of the things that we really focused on and hopefully did well at the beginning and all the way through the development of the trial was to involve patients. We had a lot of patient involvement all the way through at every stage.
Oh, yes.
It's important.
Every stage about the Engage package, about the surgical intervention, about how many times they wanted to be contacted, about how, every single stage has had a lot of patient input. And I think when we put the trial through the ethics committee, they were really complimentary about how much patient involvement we'd had from the beginning all the way through. And that hopefully is reflected in the fact that actually patients do like it because it's really been co-produced.
Yes, it's important
by patients as well. And I think hopefully that has come out in the fact that people are actually wanting to be involved. So.
Yeah, that's a good testament to doing good public patient involvement, PPI, which we talk about a bit on the podcast.
Yeah, we do.
We like PPI.
Yeah, we do like PPI.
But yeah, that's really good to see it sort of working, really.
The PPI also showed us that the patients like the non-operative arm. Because I think if you talk to some surgeons, they just think, it's they need an operation. It's going to be one of these two, and we're maybe less enthusiastic about the non-operative arm. But patients really wanted that to be in there, and we're really keen. Some of them really want to get that, so that probably changed our point of view a bit from the surgical side, that the non-operative arm might be a bit more difficult to recruit to, so patients might not join because of that. But it was completely the opposite.
Oh,
They
really?
like it.
Wow.
Yeah.
Oh, great.
And of the 20% of patients that don't go into the trial, I think it's a 50-50 split with those that don't want surgery and those that do want surgery, isn't it? So some people will say, I don't want to do it because I want X. And of that X, 50% say I want surgery and 50% say I don't.
Yeah.
So it's not just the patients that want surgery who say they don't want to go
Oh,
in.
right. Yeah. Yeah. Really important to get that patient perspective because, yeah, like you say, you might just assume surgery would be the most popular option, but yeah, to ask the patients what they actually want.
Exactly.
Really.
Yes,
How
it is.
unusual.
Yeah. Yes. Yeah. So I think now we've got some fun questions now that we're gonna pull out of this hat that we haven't warned you about. So
Okay.
you can't prep for these, I'm afraid. But they're all nice. They're all nice questions.
They're nice questions, yeah.
Do you
Hopefully.
pick the first one?
Oh, gosh. What's the most unexpected or surprising thing you've discovered so far in your research?
Well, I think we've probably talked about it, haven't we? The fact that the patients have been so engaged in the actual process, because we're not at the stage yet where we can look at any results, are we? But I think the fact that it's been, touch wood, so far really easy to get people to be involved. That's been the most surprising thing for me.
Yeah, I'd agree. The enthusiasm towards the non-operative arm, like we were just talking about, because I think, as surgeons, you're in a bit of a surgical bubble. But the patients do like the non-operative arm, so that was a pleasant surprise that it hasn't been difficult to recruit because of one arm for whichever it is. You think maybe people come with their own ideas and they definitely don't want one of the three options, but that doesn't seem to happen. It's rare when that happens.
Yeah,
it's good, isn't it? Especially when you've got three arms.
Yeah, exactly.
Yeah.
See what's next.
Oh God. This is because we're all a bit nerdy in research. What's your favourite type of chart or graph and why?
I think this is an easy one. Our recruitment graph.
Oh, yeah.
Because it's at the moment it's looking really good. So we have slides that we try and show as much as possible.
Can you show that one off?
We're going to get T-shirts made, aren't we?
With your graph on.
Exactly. It's just a very nice little line graph, but it's going. So we're ahead of the curve.
Oh, yes. So, definitely get a T-shirt with that on. Is that your favourite graph as well?
Yes, I can't top that. Yeah, that's definitely it.
Recruitment graph. I like that one. Okay, let's see what we've got now. Oh, this is a long one. Would you rather have to present your research findings entirely in rhyme or using only interpretive dance? See why I laugh?
Probably neither. But rhyme, maybe, I think, because I'm liable to injure myself if I try and do it with an interpretive dance.
Yeah, it'd have to be rhyme. I can't dance at all. So
but can you rhyme? Can you rap?
No, but it'd be less embarrassing.
Right, I'll look forward to hearing your SCOOTT rhyming, rapping.
SCOOTT rap.
Dear. Yes. Oh dear.
What was your dream job as a kid before you knew that researcher or surgeon, I guess, was an option?
I didn't really have a kind of job I always wanted to do. I almost kind of just drifted into medicine a bit.
You
I just always liked kind of science stuff, so I kind of went down that path. But there wasn't really anything. I kind of always thought I wanted to be, even if it was a bit wacky or out there or anything like that. So no, I don't really think I had anything. Yeah, a bit boring answer, I'm afraid.
No.
It's fine.
And I have a totally random answer.
Oh,
I wanted to be a volcanologist.
I don't even know what that is.
Like volcanoes?
Yeah.
Wow.
Somebody who studies volcanoes. I mean, how random is that? That's I think what I would be doing if I would be on some volcano somewhere in some tropical isle.
Oh, wow. Oh, you could do that in your spare time. You could go and climb volcanoes.
You doesn't have any spare time.
Yeah. I'll have to wait till I retire.
Yes. Once you retire, you can become a volcanologist.
Exactly. I did visit a volcano when I was a medical student. It was great. It was absolutely fab.
Wow.
Yeah, anyway, that's a different story.
That's a really cool one.
Yeah. It's a cool one, yeah. What's the favourite part of your research?
I think it's working with the whole team. I think I've really enjoyed that. It's been, because it's different. It's a different way of working, and it's a different environment to our day-to-day job. And I think having being able to work with the York Trials team, being to work with lots of different, university teams, and with Nick and Derby, and it's just been really nice working to a slightly different goal as well, and in a slightly different environment. We're meeting up today, but today will be the first time that we've met a lot of the team, because of course we do everything online.
Yes.
It's so easy to do that now. But I think working together as a team has been really enjoyable.
Yeah, I'd agree with that. I think we've got a really nice team on this trial. We all get on, have fun. So that's definitely one part of it. I suppose individual things for this trial, just recruiting the patients is good fun. If you have a clinic and you get a few, get a bit of a buzz each time you get
definitely.
you see the graph goes even higher.
Your graph going higher.
You just love that graph.
You have competition. Do you have one like, we've recruited more than the other sites, other trusts?
Nick's winning by miles.
Just friendly competition, but no, as long as we're all recruiting it's fine. But we're always happy if someone else gets some patients as well.
Oh, great. Oh, well, thank you so much for coming in today and telling us all about SCOOTT. That's really, really interesting. And I'll be watching closely to see if your graph carries on going up.
We hope so.
Yeah. And we'll have to get you back when you have some results that you can share with us and find out how it all went. And hopefully SCOOTT 2 will happen as well, and we can hear about that.
Brilliant. Well, thank you very much for having us. It's been a pleasure.
This has been lovely.
Thank you so much. And we'll put some information in the show notes if people want to learn more about the project. We'll put some links and things in there. But thank you very much.
Thank you. Thanks.
Bye-bye.
Bye-bye.
Don't forget to like and follow The Research Room wherever you get your podcasts. And if you'd like to leave us a review, that really helps other people find the podcast.
Does it?
It does, yeah.